From Tidal Health Group, this is Health Impressions, where we break down healthcare marketing strategies for consumer brands with industry experts. I'm your host, Bryan Cush. Dr. Oberg, it's so great to have you on the show. I'm so happy we got connected. I don't think a lot of audience would know us, so I'd love to just get you in your view, who you are, where you serve, and we were talking a little beforehand too that you have a very unique but often relatable story coming into this space as well.
Yeah, thanks. No, I got into healthcare when I was really young. My grandfather was a surgeon. Mom worked in a medical office, and I've kind of been in and around the space for a lot of my career, even though not directly for all of it. So I think the important part for today's conversation is that we started Precina Health, which is a medical practice serving 3 states right now: Texas, California, and Oregon, primarily to handle type 2 diabetes and metabolic syndrome, where people are sick, and in many cases we have the medicine, the devices, we have all of the protocols to make them better, but we're not making them better. And I got really frustrated about that when my mother-in-law got sick and she ended up in the hospital. And so I went back and I got a doctorate in social work to figure out why the medicine wasn't working, why the behavioral health wasn't working. When we have all these answers that work in academic settings, why aren't people getting better? And we had a pilot study of 50 patients in a low-income area with low access to care. And instead of getting 50% or 10% of them healthy, like some studies have shown, we were able to help 98% of the population get better in 12 weeks. And then we kept them better for the next 2 years. And then we opened a medical practice using the same protocols. And we're going to end type 2 diabetes as we know it. Now, we're not going to cure type 2 diabetes, but we are going to make it much less a problem than it is today. We're seeing the same results in our clinic today. We had a patient just yesterday who we reported 5% A1C reduction over a 3-month period, which, if you're in this space, is just jaw-dropping to clinicians. And we see those stories all the time in our clinic.
I'd love to peel the layer a bit more. You use the word medical practice and clinic, but I think the traditional definition that people probably think of is not how you're operating. And if that starts to step us into the personalization side, I'd love to. I hear that word and I know he probably defines it very differently than most.
Yeah, that's fair. During my doctoral studies, I ripped apart everything I could find about a medical practice down to the molecular level, and we rebuilt up our entire medical practice based on how do you make patients better in an economically sustainable way for a low-income population. What does that have to look like from a patient experience, from a provider experience, and how do you do everything differently so that patients can get precisely what they need? And you're probably more sensitive to this than most. Patients need what they need. They don't need what the statistics need. Every patient needs to be met where they are in our particular practice so that we can help them take the next one step along their journey. That's how you help people get better in our experience.
Yeah, I appreciate that comment. We firmly take the consumer's mentality into a lot of conversations, and I could endlessly probably bore and steer this conversation in the wrong direction, the amount of times that framing kind of causes friction with kind of the more traditional established healthcare is, I guess, the way I'll leave the descriptor as.
Well, yeah, but the reality is we want clinical outcomes, right? I think and if you want a clinical outcome, and that means in our case, we're talking about people that need to adhere to medicine. They have very high treatment burden. It can be very expensive to deal with that type of disease, type 2 diabetes, primarily in our case. And so I think it's okay, with all that in mind, how do you meet people where they are to help them take the step they're willing to take in their journey? And it's not just having a plan, it's having a plan that includes the expert, so the physician or the mental health clinician, and the patient, so the patient can say, here's what I'm willing to do. Because if a doctor tells a patient to do something they're not willing to do, it's not a good plan. And if a patient gives a plan that isn't the right plan clinically, then it's not a good plan. And so you have to get everyone collaborating together, which means a different clinical experience than our current system is set up to have. I think most doctors want to have that type of interaction, but our current system doesn't allow for that. So how do we work within the existing system to give providers and patients what they need so people can be healthy and we can have an economically viable outcome?
How do you? What does that start to look like? In my view, when we talk with clinicians, there's this heavy kind of polarization of practices where there's the traditional way, which everyone knows, or there's really cash pay concierge. And there's kind of these two worlds. But I think there's clearly a very different and technology driven approach that you're taking.
Yeah, look, I think I have a concierge medicine doctor, a direct primary care physician that I think is amazing. And it is a very similar model to what we're talking about with Precina. But Precina is designed to take patients, whether it's a fee-for-service environment, a direct contracted environment with the payer, or a cash pay patient. We wanted to make sure that with someone who had low income and low access to care, they would have the care they need to be personalized without having to pay extra on top of the system, which is oftentimes what happens in concierge medicine, is that it can be sometimes more costly, not always. And so, and so what we do is we bring patients into our practice, we take insurance, and we spend time with them up front to create a plan. And then we just make sure that the patients are committed to the one next step. So that means looking at like all of the clinical medical issues they have going on. We look at the behavioral health issues that are going on, and we separate those into the things that are caused by the medicine and not caused by the medicine. And then we look at a whole bunch of the social determinants of health, and we look at the ones that are actionable for the patient versus those that are not actionable for the patient. And there's a whole other set of variables you look at that don't fit into the first three buckets. And then we triage all those from an urgency perspective, and then we overlay the patient's readiness for change. And so that all sounds really exciting. Let me tell you how that breaks down in reality. We had one patient who was eating ice cream and drinking chocolate milk, and that was the only way they were willing to take calories in. They had some mental health issues going on. And so the answer for them was changing the flavor of ice cream for a week. We dropped their blood sugar by 100 points by changing the flavor, and that gave them the trust to help us make the next one step. Another patient, it was their coffee creamer, changing the brand without changing the flavor. Another patient, it was about finding their motivation in teaching young kids how to read in a part of town that was underserved. And that was what gave them the motivation to want to take their medicine. Like, these are things that you just don't typically hear in a medical visit.
Yeah, I couldn't agree more. And I don't think we'd get much pushback in the prioritization and the need for personalization. But how do you think about approaching that at scale?
Scalability is the problem, right? I mean, teaching that at scale becomes the real issue. And, we started this before AI was the LLM kind of explosion that happened. And so we were doing this, our whole pilot study happened long before large language models. And so for us, it was about what's the analog process of putting the physician and the patient at the center of it. And then large language models have just made it so much easier to reduce the burden of work for the physician and to reduce the administrative burden on the patient. And so those things just help us to do the work more effectively. But at the end of the day, we really believe that it's the patient and the provider together that create the nucleus of that success. And you can see that in all the studies and all the data. When you look at like AI only, coaching apps that are primarily technology first, I think you can bump into a problem. And we do lead with technology in the sense that all of our patients can use technology. Our providers are using technology. We're way out ahead in the AI kind of workflows. And we're talking about it like at the bleeding edge, pun intended, of AI. But we do that so that the patient-provider relationship is the central point of what we're doing.
Is there more that you could peel on that layer of thinking about that? Because I think it's an often pain point that technology becomes the forefront of the decision or the initial touch point versus it being supportive of the care interaction.
I think there's lots of things that are kind of just vanilla table stakes in the future. And that is like, if you have a patient who doesn't have a smartphone, but wants to interact with AI, having them do that through a voice-only, phone system is possible now, where it used to be interactive voice recordings. Now it's actually AI that's interacting. And the technology exists today where the patient can interact with their chart, with the physician's instructions. And for us, we can do that in a HIPAA-compliant way and safe with medicines. Like, we've had to develop some of our own AI technology to be able to do that. But we have a way of now interacting where you don't have hallucinations that cause concerns for the patient. And we've created that set of guardrails. So if a patient calls and says, like, how much medicine was I supposed to take? The AI can look that up in their chart and do that successfully and help them with correctional insulin doses, for example.
It sounds like, and tell me if I'm wrong, that those guardrails are very kind of structured data, whether that's income CRM or EMR. Is that a base point to then launching off of?
Yeah, we're using Salesforce as kind of one of our big data layers, and Salesforce has been really, really helpful in a lot of ways. They have some AI that you can use, like they have some coaching AI and some outreach AI that's really, really interesting. But as importantly, they've got an entire framework that lets people plug in their own AI. Right. So I can plug in Salesforce's AI where I want to use their AI. I can plug in our AI where I want to plug in our AI. And then when somebody jumps forward, we can actually unplug and then replug something new in with very light lift, relatively speaking. And so it creates this environment where I've got all the security layers that Salesforce takes care of. I've got the AI architecture layers that they've thought out really in a sophisticated way. And it lets us really focus on the parts where we can be expert and put things into AI that other people aren't working on. Going back to personalization, like how do you get an AI to listen to the undercurrent of a conversation that is different than the words, but listening in for the tone and those undercurrents, and then call a provider in where there's something therapeutic necessary. Like those are things we're going to work on that other people probably aren't going to work on, that become really, really important in a highly personalized environment.
Yeah, and that's an interesting, you're actually walking towards a kind of a thought, and a question I think I had was, how do you start to train or really think about like what is the ideal state that's still supportive of the human interaction, but also then kind of when is the release valve moment as well? We had an interesting conversation a couple of months ago around some of that, around that they're building systems, even just around this, the scheduling side of the AI, kind of being able to identify, almost like they called it the kind of like emptying cart kind of break point, that they would then triage and bring in a human in these different moments of engaging with the system.
Yeah. Some things we're working on right now are like having an AI listen into conversations where a therapeutic trigger goes off that someone might not catch. And so one example of that could happen where labs are being read and there's something exotic that a provider might not normally see, and say, hey, you need a consult from this type of specialist based on what we're seeing. It's outside of our practice. Let's make sure they see this physician for a consult. Or you might have somebody where they are calling in after hours and have questions, the provider's not available, and the AI can take over and say, hey, I can answer a lot of those questions for you. And if they say, well, I want to talk to a provider, it can access the scheduling and say, hey, look, we can have an appointment at this time, or if you have a quick question, we can actually get a provider on the phone for a few minutes at this time instead. So in other words, it helps providers use their time more effectively without having everything have to be an appointment. It can actually direct people to kind of knock things off the to-do list more quickly.
Is technology solving the personalization, or sorry, the scale side of this? Or is technology coming in and being a supportive of being able to go into kind of the low income and keeping it as reducing or minimizing the low cost aspect? Because there's an interesting kind of linear thought I'm trying to think of, where you said the LLMs and the AIs kind of came further downstream. Yeah. So how were you thinking about technology kind of pre and post? I'm curious to understand kind of what it's solved for, when it's and what it's allowing to grow into.
I think it's both and, right? I think it's allowing us to allowing us to lower the cost structure, but as importantly, it's allowing the provider to spend their time providing instead of administering. And so that's the way that we think about it. It's like, what can we do to reduce administration overhead and then to create more time for relationship? That's how we view things. And also, by the same token, how do you do that for the patient? So when we onboard a patient into our practice, typically we'll spend days gathering data of all of their medical records before the provider sees them. And then we have an AI go through and flag all the most important things for our process. And then a provider goes through and looks at those parts of the chart. And this will sound crazy to you. We have a provider read their medical chart before they come into their first visit. I know, it doesn't sound, I know, it's just, but we actually do that. And that way our providers know what types of questions they need to be asking, and they can have a straw man treatment plan coming into the visit and then offer ways forward for the patient that makes sense to the patient. But we want to start to see immediate positive feedback loops being generated after that first appointment. And generally that comes in the form of patient adherence to taking their medicine.
And I appreciate it. I know you said that lightly, but that is a massive distinguish than my own experience. And I would say the most experience of individuals when they're coming into an appointment and there's really this almost checkbox mentality that is the opposite of personalization. Of, did we ask them about smoking cessation? Like kind of this,
Right.
did I go through the motions vibe? And then instead of did I understand that person and already come proactively with a conversation that is unique to them?
Yeah, I think that's really important for us, and that doesn't mean that we're not documenting appropriately for fee for service. We have to do all of that as well. We have, and there's lots of people using ambient scribes, and so we try to grab all of that technology, obviously, but then we want to figure out like how do you get AI taking you forward even further, right? And so I think there's a lot of things we have that we're looking to even in the future where we can start training family members to be good support systems for families. But when they have a question, they can get together on the line with an AI, and the AI can identify anything that would say, no, no, you need a clinician involved in this part of the conversation. Please hold.
Is there more of like you gave some really pointed, simple experiences too around like the individual with the flavor change of the ice cream? Like, can you peel even more layers? Like when I think a kind of a nascent first reaction may look at that and go, "Holy crap! Like that's so personalized. How is that not time consuming on the physician's level?" Is there a more layers pull on that of like the AI flagging or prompting something to the physician, and how to think about that when you're doing more but with less time?
Yeah, I think well, I mean, part of it is that we do spend more time with a patient. Like I think when somebody comes in
What
for
a
their
foreign
first
concept.
visit, like we might spend 30, 45, 60 minutes with a patient and then spend another 30, 45 minutes with their treatment plan. And that's how we set it up. And then we might spend 2 or 3 minutes on a phone call with them for the first week every single day if the patient has that kind of questions, right? Like, and that's okay because what you're doing is you're teeing up that long-term success for them, right? And we have so many idioms in our culture about why this is important. A stitch in time saves nine. An ounce of prevention is worth a pound of cure. Like we talk about this in all these places, but our system is set up as a sickness treatment system, not a healthcare wellness system. And so we take people who are sick, and the first thing we've got to do is assess where the problems are at the root cause. That's our first phase of what we do in our practice. And then the second phase for us is all about disease control. Like, how do we get disease into control? And we do that extraordinarily well and extraordinarily quickly. Then our third phase is about stabilizing the lifestyle. And then our fourth phase is about lifestyle intervention and wellness. And what we find is that too often we try to go straight to that fourth phase and we skip phases 1 through 3. That would be akin to like me walking up to someone on the street and be like, "Hi, my name is John. We should be best friends. What do you think?" It's just weird. It's creepy. And so so we don't skip steps in those relationships with the patient.
How do you begin to kind of, we've walked a little bit through obviously the reduction from like a clinical kind of quantitative, you mentioned some of the A1C examples. Can you talk a little bit more about kind of some of the behavioral and lifestyle tracking that you just mentioned, and maybe how the patients are interacting with the clinician or even the technology themselves in between those appointments?
Yeah, obviously we have people that are interacting with technology every day, putting data in about what their blood sugar is and what their medicines they're taking, and we have patients with hypertension that give us blood pressure readings, and CHF we have people on the scale, and so we have all those kinds of metrics. All of that not new. Like there are people doing remote patient monitoring in every part of the system today, and which is fine. We just want to make sure that remote patient monitoring leads to immediate feedback loops where people are getting positive and critical feedback about where they need help. And so I'll give you an example. We had a patient who was in control for a long period of time and their blood sugar spiked, and I can't remember the number, so I'll make it up. But let's say, you want to be below 100 when you're fasting, 140 when you're eating, and this person pumped up to let's call it 300. On the phone with the provider's like, "Hey, you've been in control for months now. Is everything okay?" They said, "No. What's going on? I'm visiting Miami. What's the story? I'm seeing my in-laws. I just ordered a whole pizza and ate 3/4 of it." Got it. Do you need some help? No, I'll be fine. It's great. Keep tracking. Let us know what's going on. And they were fine within 2 days. Like we got them right back in, but they needed just a quick 5-minute outlet.
Yeah,
And just
and it's
knowing
got a
someone
call.
was there was help. Yeah. That's
How do
not
you
less
think?
time. That's more time with the patient, right? Not
Yeah.
less time.
Yeah, we talk about that concept a lot. Is like, is this the highest and best use of my time? And
Yeah.
that's
Top
really
of
just a lens within healthcare that I think is only more appropriate now.
Yeah, top of your license. You want people working at the top of their license. And so we take our providers and we train them. We spend 30 to 90 minutes per week training our providers on our set of protocols and how those protocols work both with technology and with the patient to make sure they understand. Like we think we've found a new way to treat metabolic syndrome. I think we've had the medicine for a long time. We have some great new medicines, GLP-1s and SGLT2s, and there's some great new medicines for sure. But like that pilot study I told you about, where 49 out of 50 people we controlled in 12 weeks, that was only using metformin and insulin. We weren't using GLP-1s. We weren't using SGLT2s. That was just metformin and insulin. So we've had medicines that'll work for a long time. We've got the right devices. When I went in to do all that research, it was really about what was the missing piece, and they just weren't put together correctly. And so what we've done is put them together in a new series of protocols that we believe will turn into a new subspecialty of medicine, which is metabolic syndrome treatment, right? And will help people have the right medicine, have the right behaviors so that type 2 diabetes becomes a thing of the past. Hopefully we'll get insulin resistance into control, and then we can start focusing on things like hypertension, CHF, COPD, asthma that all have similar treatment mechanisms to get people to get into and stay in control.
Yeah, I keep hearing these kind of two meta recurring themes just around adherence and support, and even to me that jumps out even more when you make the reference that you're using drugs that are already been in existence and not even tapping into what's kind of the new and innovative side.
Yeah, that's right. And it's like part of its habit, right? And I think I had a whole conversation yesterday with someone about like the brokenness of the healthcare system, and it's true that our healthcare system is imperfect. It's true that there are things we can fix today, and it's true that there are things that'll take a long time to fix. Our stance toward the patient, just being really pragmatic, is this: the system is what the system is today. There are things you can do and control right now to help yourself, despite it being a difficult environment. So let's do what we can do today. And we can still try to fix the environment and fix the process and fix the policy. All the work should be being done. But for today, how do we get you medicine? How do we get you the right medicine? And how do we get you controlled and then stabilized? Like those are things we can do today, despite the difficulties.
Do you find any kind of pushback from patients as well? I don't know if there's a question in there, like there's almost a receptiveness that they have to be in a state to understand that and understand that space to take that step forward.
Everybody is in a different place of readiness for change, right? And that can be from maintenance, because I've already made the change and I'm maintaining it, to pre-contemplation, I haven't even thought about it. And so remember I told you we look at all these different factors and then we layer across the top readiness for change. And we help the patient change where they're ready to change. Because if I ask someone to change in a place they're not ready to change, guess what's not going to happen? Right? They're not going to change. And so I'll give you another great quick story. We had a patient who needed dialysis or they needed insulin. Those were the two choices. And if they didn't choose one of them, they were going to be dead within 60 days. And so they said they didn't want to take insulin and they didn't want to take dialysis, didn't want to have dialysis. And so my team called me in as the behavioral guy and said, hey, look, they're opting for neither one of those things. You're on deck. Your call. And so I called the patient and said, hey, this is Dr. Oberg. My team tells me you don't want to take insulin. They said, I don't. I said, great. I support your decision. They said, you don't want dialysis. I don't. I said, I support your decision. I need to get you a referral to a palliative care doctor and make sure that you have an estate attorney. They said, what are you talking about? I said, well, they also mentioned to you, and you may not have heard this, but they mentioned in your chart that you're going to be dead in 60 days. And so I want to make sure that you have a will. I want to make sure you're talking to a palliative care doctor about how to pass away, in the most peaceful way possible. Can we talk about that? And they're like, excuse me? It's like, well, you may not have heard this in your appointment, but you're going to die in 60 days. And they're like, well, I don't want to die. And I said, okay, well, I support that too. Now, here's the challenge. It can't be true that you don't take insulin, don't take dialysis, and don't die. Like one of those things can't be true. And so they said, well, I don't. And so we walked through it. And what it turned out to be was they were nervous about taking shots. and they didn't want to go to a dialysis center. And it's like, okay, well, help me understand, which one do you want? And it ended up we had insulin in their home by the end of the day. We got them comfortable taking shots by getting people on the video with them, so we could actually walk through it with them and not literally hold their hand, but virtually hold their hand and take all the time that was necessary to get them exactly what they needed where they were, which is comfortable taking an insulin injection.
Yeah, what a beautiful and painful example. And I think what I hear is so funny. It's just like a simple base human psychology underneath that. It's just like the adage of like, you need to hear something 7 times before you hear it once. And if that patient was guarded to just that single interaction, what downstream kind of massive adverse effect or outcome may have happened even before death that would have brought them into the healthcare system in a different way as well.
When education, I tell people all the time, education only comes once you understand the motivation. Like, we don't educate people about what to do or how to do it until we understand why they want to do it. Like, what's their reason why? And the patient's why is the powerful thing. It's not the doctor's why. Our why doesn't matter. It's the patient's why that matters. That's how you personalize all of this for them. And so teaching our providers, I was talking to my providers, Wednesday about this, and I was like, I don't think you've learned this in school. And they just laughed. They're like, we didn't even talk about this topic in school. And this is why it takes us, hours and hours per month to help sensitize our people to this part of the protocol, which is uncovering the why for the patient so that we pick the right treatment plan. And that treatment plan changes over time for people. Like, that's what personalization is all about. And so how do you do that at scale? Well, you have lots of technology and processes and systems that kind of wring out the excess unneeded things so you can focus on what's really important, which is relationship. And then we don't focus on efficiency in the relationship. We focus on effectiveness. And that sometimes takes time.
Yeah, and it's funny. I've heard a couple lines towards this throughout, and I may be steering this conversation in a whole nother direction, but it's funny that you said that our why doesn't matter, and then you pointed out the amount of minutes you use to train the physician. And I think that's such a breath of fresh air that I even as a non-MD, I can tell you that no one's being trained that. I'm curious, like, how much of your day, or how do you think about the physician education side of this?
I mean, our people are essentially going through a whole fellowship, right? I mean, because it's like a whole nother fellowship for them. And now it's not technically speaking. So for any MDs listening who've been through a fellowship, they're like, that's not a fellowship. Yeah. I know it's not a fellowship, but it's that level of thoughtfulness about how we review cases and how they're being trained. And we role play with our physicians like the beginning of a patient appointment, so they know that we have a standardized way for every single appointment to start, to make sure that we're starting the appointment by meeting the patient where they are and not assuming that the patient is where we left them 2 weeks ago or 4 weeks ago or 12 weeks ago, because their life may have changed. And we just need to check in for 30 seconds about that or 10 seconds about that. And teaching our people how to do that in a way that's both process driven, but doesn't feel like it's checking a box. It's truly listening. Not one of our providers, but I had somebody else outside the practice ask me one time, how do you get someone to think you care about them? I said, it's really easy. You actually care about them.
What a foreign concept.
I know. It's just, and they were, I mean, it was just like, whoa, it's like, come on. Man. I think most MDs and healthcare providers do actually care about people. That's why they came into the space. And so I don't think that's a problem in healthcare by and large. I think most providers really, really, really do want great clinical outcomes, really, really do want everyone to be, economically sustainable, themselves included. And I think we just have a system that needs to pivot. And the system was built for the right reasons at the right time, but it's time for it to change. And so we believe we've got to change that from the inside of the system.
Where is Dr. Oberg looking towards and most excited? It could be if it's a technology lens, or where is your eyes on the horizon?
Yeah, a couple things. We're using technology right now. We think we can lower the cost of some mental health care delivery by as much as 95 or 98% within the next 18 months. And so we're developing some technology to do that by engaging paraprofessionals in the process and communities. And in doing so, we're going to engage retired adults who can be drawn into the system and not feel marginalized by the system. And so that's one of the things we're excited about. Another thing I'm geeking out about right now is I'm diving deep into like the academic understanding of FBI psychology for hostage negotiation when someone isn't willing to negotiate, and how that can be used to someone who's stuck in their own healthcare journey, or things we can clinically appropriately talk to a patient about when they don't want to make a change, but maybe they should, like what's clinically appropriate. And I don't have good answers for that yet, but I want to see if there's some cross application from like that hostage negotiation science that we can bring into like, a tough clinical situation.
That's so interesting. Is there any lens or maybe hypothesis you can pull from that? My first thought goes to like, yeah, those are very high crisis, high neurochemical moments, that there has to be some bridge between those scenarios.
Yeah, I don't know yet. I mean, I think that to me, it seems intuitive that when you've got someone who's in a hostage situation that doesn't want to negotiate, that they're stuck and they need to get unstuck, and that you might have some of that same stuff happening for someone who's had the same 40 years of behavior. And so my hypothesis is there's something we can learn in what the FBI has done, and we can cross-apply that into a clinical situation where it's clinical. But again, you're in a clinical situation with a patient, and you're not in a clinical situation with a hostage negotiation. So you've got to be really careful that you apply those things appropriately, if at all. And we're very early in the kind of evaluation of what's happening. But it's fun for me to find like a whole new separate area of science. Like, when we looked at this for diabetes and for hypertension, I did a lot of work looking at what has been done in the world of HIV, because they've done such a great job of controlling, HIV over the last 30, 40 years. And then there's a lot of things you do in substance abuse assessment, in terms of like screening, brief intervention, referral to treatment for mental health conditions, that cross apply into the work we're doing. So I'm a huge fan of like taking best practices we've learned somewhere else and then trying to cross apply them here, so we don't have to start from the drawing board.
Yeah, this group and this audience and many of the guests we've spoken to, that we've come to that topic a lot of just learning best practices from either adjacent or really just non-linear categories. Heavily in hospitality, you're even seeing it with some like the hiring side and in healthcare, bringing just that kind of consumer hospitality into healthcare, which again, should probably not shocking to you, but it is shocking to the more core healthcare category.
Yeah, I mean, 20 years ago, I did a case study in my master's program that there was a group of, I don't remember which hospital it was, maybe in the Carolinas, that took a group of executives out to a 5-star hotel in California and had the entire executive stay for the week and then take notes on everything the 5-star hotel did that they had to take back to their hospital. And I think you've seen a lot of that in hospitals, particularly in the OBG or the labor and delivery, L&D wards, where you see like just a much higher level of service. And so I think that if we could help patients become better consumers of their own healthcare and take agency into the kind of clinic, I think we're going to see a more educated group of people coming in and taking more responsibility for their healthcare. And that's going to be one piece of what we need to see happen. Not to say that we should be confusing a Google search with a medical degree. I don't think that's healthy. But I do think that it's healthy for patients to want to be their own agent in the process and to ask questions. And that means that physicians and all of our providers are going to need to be thoughtful and patient with the patients about answering questions and getting them educated, and so it's only going to help the process.
Yeah, it's a fun example. I wonder if we interviewed a Dr. Newworth, he's a clinician by trade, but I think he was a chief innovation officer at Atrium Health across Carolinas. And he talked a lot about that. He really reframed the entire health system to define them as consumers and to really think about them not just in that 15-minute increment as a patient, but what is the universal journey that they're experiencing in and out of our health system. So whether that was the example or not, really made me think of there is a lot of education being done in that space.
Yeah, and yesterday I spent time with a patient who they just needed help shopping in the grocery store. And so we spent time going through literally what a meal plan might look like that works for them, and then what a shopping list would look like. And we were using AI, of course, to short circuit the heavy lift of all of it. And it just made it so easy to use technology to say, okay, well, here's a meal plan for the week. And what does this look like to you? He's like, well, I don't like this. Okay, well, I don't like that either. So let's cut that out and let's cut this out. Let's reprompt the engine and then let's make a shopping list for you. And then are you going to have time to cook? And do you want to make a schedule? And it really helped them feel like they had agency for what they wanted so they could take their health journey that next one step at this part of the journey. And so I think there's a lot of places that technology is going to help lighten the load for people. But there's so much new technology. We're early days right now.
Yeah, and there is. It's funny, there's a lens too that we've seen. And be curious if you track this or just even honestly just your educated response to it. Of there's this moment when you meet them, a consumer where they are, that they lean in more. There's then this kind of further pressing to the pedal that there's an engagement and now an incentivization in their healthcare. And one example where I'm now calling to mind is we were speaking with a specialty pharmacy around patients with hemophilia. And there's numerous types, similar to your example, of that patient at home that's just afraid of the shots, afraid of just how is this gonna tether me to my house? Will I ever get to leave again? And every time they'd peel away and they'd understand the difference of themselves against a lot of their competitors is they would just mail out the drugs, and then the drugs stacked up at these people's homes, and then they expired, and then it actually caused an inverse incentive that the patient stopped reaching out. Where that moment of kind of meeting at that fear state, they're actually now getting their patients, they see over a linear path that they lean in more to go, well, okay, you've relieved this burden, like what other misconceptions do I have about my disease or about this category?
Well, and I think that, with that, and again, I had a conversation this morning with someone around, like, we can't drink our own Kool-Aid. Like, we really have to understand what their experience is, and we've got to get comfortable with not liking the answer, right? But if we're not dealing with the truth, then we're not able to make the impact that we want to have. And so we've got to get, scientific about it. And that means that you've got to be objective about what's happening and look unemotionally at a highly emotional situation from the patient's perspective, even the provider's perspective in some cases, and really kind of say, okay, how do we get our own Kool-Aid out of the conversation and figure out, like, what is the patient reacting to? What is the provider reacting to? What, that's hard work to do. And you've really got to slow down. And for us, we talk about getting granular. Like, how do you really get granular around every little interaction that's happening?
Well, I've appreciated this conversation, and I'll say it's definitely a breath of fresh air. And it's funny as more on the marketing side. If we had degrees, honestly, I think I would bestow you kind of a degreed brand strategist. If you've never heard that before, you really have that ability to just put your ego away. I mean, that's the hardest thing, is how do you actively listen to that other person and meet them where they are. And then that's the heart of what we do, is you really have the spirit of a brand strategist. So.
Well, hopefully we've got, what this leads to is, 3.5 billion people in the world have some type of chronic disease. And so in the next 50 years, we want to make it a little bit better for 1 billion of them. And we know we're not going to do it just from, our particular practice. Like, our goal is not to have 1 billion patients in our practice, but it's to teach people how to have that right empathy, meet people where they are. And hopefully we change the face of healthcare in a way that we can change it, even given some of the difficulties we have today. So that's the hope.
Yeah, and it sounds like you're doing some great work. It is a framework that sounds very applicable to so many then different subsets of healthcare. So
yeah, we're excited about it. Thanks for having me today. I really appreciate the time to come on.
Yeah, equally. Is there a best place, if it's Precina, yourself, that kind of people can reach out to you, engage on?
Yeah, Precina.com, Precina, Precina.com. And then, I've got we talk about a lot about personal accountability, responsibility at talesofabundance.com, which is a podcast about just how people can think more abundantly and have more, positive, hopeful stories about their day. And sometimes people just need that to feel good about what's next and stay motivated. So Precina.com, talesofabundance.com. And, if anybody has questions about, chronic disease, wants to reach out, I'm pretty accessible. My team will find me, and I'll reach back out.
Well, absolutely love that name. Shockingly, I actually didn't know it, but we have a funny saying internally here of things are just problems of abundance. So I love that name.
Yeah, that's great. Thanks, Bryan. I really appreciate the time.
Thanks for listening to Health Impressions. Subscribe on your favorite podcast platform so you never miss an episode. Leave a review to help us improve, and connect with us on social media.
Keep exploring, learning, and pushing boundaries. Tune in again soon.